Hello viewers, today I will discuss about how to approach to red eye. Okay, first we will learn about some anatomy of the eye. Eye will consist of three layers. The sclera, this is outer supporting fibrous layer. The uveal tract, a vascular layer, consists of iris, ciliary body and choroid. And the retina, the neural layer. Here is the retina, here is the choroid, and this is the sclera. Now, anatomy of the eye. There are three chambers in eye: anterior chamber, posterior chamber, and vitreous chamber. Anterior chamber, fluid-filled space between iris and cornea. There is the between this iris and this cornea there is anterior chamber, and posterior chamber is there is between iris and lens. This one between iris and lens there is posterior chamber, and vitreous chamber. This is vitreous chamber, contains thick gel-like fluid. Now, conjunctiva is thin, transparent layer of vascular mucous membrane that lines the posterior surface of the both eyelids, and this is called palpebral conjunctiva. And this fold back anterior of the anterior surface of the optic globe, that is called bulbar conjunctiva. Now, for diagnose red eye, we have to take a very good history. Okay, what history we will take? Number one, onset and duration of redness. Two, exposure to sick contact, recent upper respiratory tract infection syndrome, and history of allergy, especially allergic rhinitis, asthma, atopic dermatitis, and use of new cosmetics, soap, lotion around the eye. You will ask about vision changes, very important this one. You obviously ask about vision changes, and you will ask about ease, scratching sensation and pain, and you will ask about discharge, either it is watery or purulent, and this timing, volume of discharge. And you will definitely ask about photophobia, history of injury, trauma, and contact lens use, and history of preboscitis, eye diseases. Now come to physical examination. Physical examination, what you will check for pupil size, reactivity to light, and assess for conjunctival discharge, color, consistency, is there in debris on the eyelashes, and inspect for lid edema, vesicles, allergic sinus, and inspect for photophobia. May be suggest more sinister findings like iritis, and you can check for consensual photophobia, which occurs when shining light into the unaffected eye causes pain in the affected eye when the affected eye is shut. You will assess for physical, visual acuity, assess for extraocular muscles movement for nerve lesions. Here I have one mnemonic. All the extraocular muscles are supplied by nerve 3 except SO4 and LR6. SO4 means superior oblique, they supplied by cranial nerve 4, and LR6, that means lateral rectus, this supplied by nerve 6, that means superior oblique is supplied by trochlear nerve, and LR6 means lateral rectus is subluxus by ablutions now, and you must assess the swelling of periorbital tissue. Invert eyelids to assess foreign body. Check for globe tenderness by digital pressure through the lids, and assess for lymphadenopathy. Now, how we to approach to red eye? If patient presents red eye and there is pain, you will assess for what type of this pain. Is it mild or no pain? With a normal blurring or mild blurring of vision or normal vision, and then you will check for hyperemia. Is there focal hyperemia? Goes for episcleritis? Is it diffuse hyperemia? You will check for discharge. If there is no discharge, this subconjunctival hemorrhage. If there is discharge, you will check this discharge is intermittent or continuous. If there is intermittent discharge, this is dry eye, and if there is continuous discharge, you will check for either discharge is watery or serous, or either discharge is mucopurulent or purulent. And if there is watery or serous discharge, you will check for itching. If there is mild or known itching, this is viral conjunctivitis. If there is moderate to severe itching, this is allergic conjunctivitis. And if there is mucopurulent or purulent discharge, this may be chlamydial conjunctivitis or acute bacterial conjunctivitis. Now, if patient present with red eye with pain, and this pain is moderate to severe, and if it is associated with vision loss, distorted pupil, and corneal involvement, you did the differential diagnosis will be herpetic keratitis or subacute bacterial conjunctivitis or keratitis or corneal ulcer or acute angle glaucoma or iritis or traumatic eye injury, chemical burn or scleritis, and all this needs emergency ophthalmology referral. Now you will go for corneal abrasion. Corneal abrasion, can you remember where blood supply of cornea? Yes, cornea is vascular. It gets nutrition from surrounding vessels and anterior chamber by diffusion, and while the corneas get from nerve supply, it is from trigeminal nerve, first division, that means ophthalmic division, and through long ciliary nerve. And corneal abrasion can be treated by primary care physician and usually used by mechanical damage of corneal epithelium, usually due to minor trauma or contact lens uses. And signs symptoms may be pain, redness, photophobia, and foreign body feelings. Pain usually relieved by topical anesthetics. Treatment, topical antibiotics and analgesics. Most abrasion clear spontaneously within 24 to 48 hours, and pacing not important, indicated for simple abrasion less than 10 millimeter. Here is the corneal abrasion, you see there, corneal abrasion. And now adult chlamydial conjunctivitis. Yes, it is viral infection caused by chlamydia trachomatis, serotypes D to K. Usually with sexually active adolescents and adults, it may be present with plus minus genital infection. Chronic cases may be with mild keratitis. Symptoms, signs and symptoms usually unilateral. There is foreign body sensation, lid crusting with sticky discharge may be present. Also follicle may be present. Usually no response to topical antibiotic alone. How you diagnose? You will take swab or smear, sometimes PCR, and sometimes direct monoclonal fluorescent body microscopy. Treatment with topical tetracycline or doxycycline or erythromycin. You have to contact trace and urinary medicine referral. And you see, this is adult gonococcal conjunctivitis caused by bacterial infection, Neisseria gonorrhoeae, acute onset, profuse, purulent discharge, and conjunctival hyperemia and lymphadenopathy. And keratitis in severe cases, there is risk of corneal perforation. And what investigation you will do? You will do gram stain, culture and chocolate agar, and treatment with IV cefotaxime, topical gentamicin, and urinary medicine referral and contact trace. This is viral conjunctivitis, usually caused by adenovirus type 3, 4, and 7, which cause pharyngoconjunctival fever, and adenovirus type 8 to 9. It causes epidemic keratoconjunctivitis. And what symptoms? It will acute onset, bilateral, watery discharge, shortness, and foreign body sensation. Often there is no photophobia and history of upper respiratory tract infection. Viral conjunctivitis may be associated with follicles and hemorrhage. There may be inflammatory membranes and lymphadenopathy, especially pre-auricular lymph nodes. And keratitis occurs on 80% of epidemic keratoconjunctivitis and 30% in pharyngoconjunctival fever. Treatment, no specific therapy. It is self-resolving after 2 weeks. You will tell patient it's very contagious, and topical steroids for keratitis if risks for scaling. Allergic conjunctivitis. Allergic conjunctivitis at 3 quarters is atopy. Tutors have family history of atopy, and symptoms signs usually there will be itching, bilateral water discharge, and chemosis. Papilla can be present. Sometimes it is in chronic cases it is giant cobblestone like papilla. Allergic conjunctivitis investigation you will do with IG levels, pest testing like this, and you exclude the infection like viral infection. You should exclude. And treatment, it is cold compression, remove allergens, NSAID and histamines like this. And this martial stabilizer you can use like sodium chromoglycate, topical corticosteroid and immunosuppressant like cyclosporine for steroid-resistant cases. And now comes to bacterial conjunctivitis. You see there in bacterial conjunctivitis, too much discharge and mucopurulent discharge is there. So common cases is staph aureus, staph epidermis, pneumonia, hemorrhaging fungi, direct contact with the infected secretions, And symptoms is subacute onset redness, grittiness, burning, mucopollulant discharge, often bilateral, no photophobia. And signs is there is crusty leaves like this, hypheremia, mild papillary reaction, leaves and conjunctiva, maybe edematous. Investigation swab you can take if diagnosis is uncertain, not routine. And treatment with topical antibiotics effective in 2 to 7 days, except in very severe infections. And chloramphenicol and fusidic acid is appropriate first line of treatment. And subconjunctival hemorrhage. This painless red eye without discharge, visual acuity not affected, clear borders, mass conjunctival vessels. You should check BP, no treatment is needed. Can use lubricants like artificial tears. It takes 10 to 14 days to dissolve. If recurrent, you should check coagulation disorder and full blood count. Remember about this skull fracture trauma where there is subconjunctival hemorrhage may be present. This is the recognized in case of a skull fracture. Periorbital ecchymosis is a sign of base of basal skull fracture or subgleal hematoma, acrantomy that ruptures the meninges. Now we can very important topic, acute angle glaucoma, and it needs immediate treatment to prevent irreversible glaucomatous damage from the raised intraocular pressure. And aqueous human is produced by ciliary body. Here it is produced ciliary body, and in the posterior chamber of the eye, and it diffuse from this through the pupil and comes to the anterior chamber, and from the anterior chamber the fluid is drained into vascular by a trabecular meshwork and canal of Schlemm. And you see this is closed, canal is closed, so it is called angle closure glaucoma. So what is the sign of symptoms? Symptoms are severe ocular pain and headache. Other symptoms are nausea and vomiting. There will be decreased vision, cut, halos around the eyes, and photophobia. So what are the signs? And this semi-dilated non-reactive pupil, ciliary injections, and corneal edema is there, and shallow anterior chamber, flaring anterior chamber, raised IOP, and eye will be tense on palpation. What are the association? Age is average 60 years, males, female ratio is 4:1, and female are more sufferer. And there may be family history also, and hypermetropia. What is the treatment? Treatment is here you can mnemonic one. A stamp. A stamp is what? A stamp supine position, left flat, and temoloride drop, acetylchemolomide 500 mg per oral or IV, mannitol 1 to 2 gram per kg IV, and pilocarpine drop. So what is pilocarpine? It is cholinergic parasympathetic mimetic. It causes ciliary muscle to contract and meiosis also. And I told already acetylchemolomide and temoloride you should use also. And surgical management, and there is laser iridotomy, and it's the curative in most cases and prophylactic to other eye. It is very unusual for someone who had an iridotomy to have angle closure again. And now this is STYE, this staphylococcal abscess on the lash follicles. It's associated with gland of Jason mole, tendal nodule of the lid margin pointing to the skin. Treatment is hot compress, ablation of lash associated with infected follicles, and topical antibiotic ointment. And this internal hornulum, this staphylococcal infection of the Meibomian gland, tendon nodule within the tarsal plate may be associated with cellulitis also. What will be the treatment? Hot compress, topical antibiotic, incision drainage after infection is subsided. Is herpes simplex keratitis, reactivation of the latent herpes simplex virus type 1 is migrated down to the trigeminal nerve to cornea, and there will be usually history of cold sores and stress. Signs and symptoms are tearing, light sensitivity, pain, hyperemia. Sign corneal sensation is reduced. You will find one dendritic ulcer is there. You see like dendrite, this one. And geographic amoebic ulcer can develop if there is incorrect use of steroids, and treatment usually topical and cyclovin and ointment 5 times daily, and cyclopentolate. You can use cyclopentolate. What is cyclopentolate? It is anticholinergic and it is mydriatic also. And what it does? It is relaxation of the sphincter muscle of the iris. And herpes zoster reactivation, it is a crusting and ulceration of the skin innervated by the first division of the trigeminal nerve. Lesion to that is tip of the nose. It is the Huntington signs. It's increased chance of ocular involvement. And treatment with oral scrobby for within 48 hours of onset of vesicles, 800 mg 5 times per day for 7 days. Maybe no effective use later, and cyclovir ointment you can also use. And ocular complications include conjunctivitis, uveitis, keratitis, scleritis, and optic neuritis. And bacterial keratitis, it is caused by staph aureus, staph pyogenes, staph pneumoniae, pseudomonas. There is predisposition of to contact lens users and pre-existing corneal diseases like neurotrophic keratopathy. You should remember simple 2 mm ulcer can be rapidly spread, so should be careful. And symptoms, signs, ocular pain, watering and discharge, foreign body sensation, decreased vision, photophobia. And signs is corneal lesion or ulcers may be visible, corneal edema, and hypopyon. What is hypopyon? This is the pus in the anterior chamber, right? What investigation you will do? Investigation is culture, blood agar for most fungi and bacteria except Neisseria, chocolate agar, Neisseria and Moraxella, and separate agar for fungi. Treatment: Ufoxacin regime initially hourly, subsequently 2 hourly in working hours, and after you can taper. Then sacubitril/late TTS you can use, and steroid when culture become sterile and evidence of improvement. 7 to 10 days after the initiation of treatment. You see very characteristics type ulcer. Fungal, this caused by fungus, and PCTP event of fungal keratitis is trauma with vegetable or organic matter, a thorn injury in agriculture workers, trauma with a wheat plant while cutting harvest is typical, and treatment with antifungal eye drops like this. This is fungal. Anterior uveitis, or it is sometimes called iritis, sometimes called iritis like this. It's inflammation of the anterior uveitic tract. 70% cases is idiopathic and associated with systemic diseases like sarcoid, ankylosing spondylosis, inflammatory bowel disease, Ritter syndromes, psoriatic arthritis, juvenile chronic hepatitis infection like bacteria, TB, syphilis, leprosy, and viral herpes simplex virus, herpes zoster virus, HIV, and fungal. Ocular entities like post-trauma, lens-induced retinoblastoma, lymphoma, all kind of this. And symptoms and signs of pain, there is pain, photophobia, limbal injection will be there, blurred vision, people will be myotic, and poor-reactive slit-leg angiogenition. You can see flare in the anterior chamber and cells in anterior chamber. There may be keratic preseptal like this, and on the back of cornea, and there may be hypophyema. There is hypophyema, see, and repeated attack can happens. And investigation, you can do a chest X-ray, lumbar X-ray, audioimmunoserology, SLB27 in severe cases. Treatment with mydriatic and cyclophagic to break the Scheinecke. So what is Scheinecke? This Irish, this adjoining of the iris and this cornea. And topical steroids, depending on severity, initially you can use for half-hourly minute. Subconjunctival steroids is if it is very severe. And now we'll discuss about preseptal and orbital cellulitis. You see there it is preseptal and it is orbital cellulitis. Eyelid is separated by preseptal and postseptal areas by orbital septum. And what is orbital septum? It is a fibrous membrane that originates from the orbital peristeum and insert into the anterior surface of the tarsal plate. And preseptal cellulitis, infection of the subcutaneous tissue anterior to the orbital septum, and orbital cellulitis is infection and inflammation within the orbital cavity producing orbital signs and symptoms. Preseptal cellulitis is usually caused by Staph aureus, Staph epidermis, Streptococcus, and orbital cellulitis is mainly by Staph pneumoniae, Staph pyogenes, Staph aureus, Haemophilus influenzae, and anaerobes. And preseptal usually follows periorbital trauma and dermal infections, since it is treated with augmentin or first generation cephalosporin worm complex and topical antibiotics for concurrent conjunctivitis. Failure to respond within hours, you can use IV antibiotic, and for pediatric patient, admission is better, and may be needed imaging if unable to examine eye. Orbital cellulitis, there may be additional signs like proptosis, chemosis, ophthalmoplegia, and decreased visual acuity. And orbital cellulitis most commonly secondary to ethmoidal sinusitis, and this needs immediate referral, need admission for IV antibiotic and imaging as risk of raised intraocular pressure, endophthalmitis, optic neuropathy, meningitis, cavernous sinus thrombosis, superior orbital infections. And this pterygium, this fibrovascular growth from conjunctiva to cornea, excision of the pterygium needed if it is in the visual axis. You can do conjunctival autograph or amniotic vein like this. Children, mitomycin reduce the recurrence. Pinguicola. It is a yellow-white deposit in the bulbar conjunctiva. This is yellow-white and may become inflamed. It is pinguicolitis. Treatment is usually unnecessary at close space, low and absent, and topical fluorometholone. It is topical corticosteroid you can use for pinguicolitis. And trichiasis, this is an inward turning of lesions, usually lashes, turning of lashes, and usually idiopathic or secondary to chronic blepharitis, and herpes zoster ophthalmicus. And symptoms of foreign body sensation and tearing is there, and treatment with lubricants, ablation, electrolysis if there is few lashes, and cryotherapy if there is many lashes. Episcleritis, what is episclera? Is tissue between conjunctiva and sclera, and you understand this inflammation in this area is episcleritis, and it may be sectoral or diffuse, and symptoms often asymptomatic, mild tearing and irritation, tender to touch, and vessels blanched with phenylephrine. What is phenylephrine? It is alpha-1 adrenergic agonist, and is dilates pupil, and it's usually episcleritis self-limiting, but may last for months. And treatment with lubricants, NSAID like this. Rarely you can use low dose steroids. Scleritis, scleral inflammation with maximal congestion in the deep muscular plexus, and symptoms are pain often severe and boring, and significant ocular tenderness and movement and palpation, and watering and photophobia is there. Appearance is bluish red, localized, diffuse and nodular. Usually immuno rather than infectious. 30 to 60% is associated with the connective tissue diseases, and most commonly with rheumatoid arthritis. And treatment, you should treat underlying condition, and NSAID, corticosteroid, and immunosuppression. Blepharitis, it is the inflammation of the lid margin characterized by lid crusting and redness, and telangiectasia, misdirected glass, STYE, and conjunctivitis are association, and staphylococcus and other school for the major causes. Often Mabuvian gland abnormalities there, sign and symptom, foreign body sensation, gritty itching, redness, mild pain. Managed treatment is lid hygiene, diluted baby shampoo, topical antibiotics, lubricants, doxycycline for Mabubian plants and rosacea. 200 mg stat and 100 mg OD, like this. Subtarsal foreign body, this subtarsal foreign body, history of foreign body must divide the eyelid. You should tell patient to look down and everting the lids, and easiest to evert laterally, remove with cotton bud and stain with fluorescein if there is abrasion. And you can use antibiotic also. Corneal foreign body, there will be severe pain, especially during pinking. There may be watering also. And remove foreign body with the cotton bud if happen to under topical anesthetics. And what is the treatment? It's chloramphenicol ointment or subtendulate. And abrasion crossing the visual axis, you should refer if there is high impact history like hammering or grinding without protective eyewear. Exclude intraocular foreign body by imaging. Endophthalmitis. Endophthalmitis is a inflammation of all chambers of eye, and vision often reduced to finger counting or hours, usually following intraocular surgery like cataract surgery and other surgeries, and may have significant hypopyon. You see here significant hypopyon, and this needs emergency referral to ophthalmology. Ophthalmial neonatalum, it is neonatal conjunctivitis by definition, present during the first month of life, but usually it follows after birth due to the contracted infection with in the birth canal, and with Neisseria gonorrhea and chlamydia. Trachomatis, it is now rare because of routine use of antibiotic after birth, and if you find disease, you can treat with antibiotic. Usually need systemic antibiotic, and like penicillin, ceftriaxone, and erythromycin, and you can use topical antibiotics like preseptal also, and erythromycin drops also. Acute necrocystitis, usually secondary to nasolacrimal and dark obstruction and tearostasis, and it is treated by systemic antibiotic, warm compress, and is their surgery after acute infection is controlled. Now HYPHEMA, this is a combination of blood in the anterior chambers of eye, a space between the cornea and iris. And HYPHEMA usually frequently caused by injury and may be partially or completely block the vision. So always take the ophthalmology opinion. Chemical injury of the eye may be acid or alkali substance. Alkali are more dangerous. Copious irrigation with a normal saline. After irrigation, corneas should be thoroughly searched and cleared. And treatment with cycloplegics, topical antibiotics, and paging. Pain medication you should give and quickly refer to ophthalmology. Now case scenario, 28 years old female, contact lens user, present with pain, decreased vision, redness for 2 to 3 days. On examination there is white corneal opacity. Okay, this is cornea ulcer or keratitis. Now case scenario 2, elderly patient with severe right eye pain since one day associated with loss of vision. On examination, vision is reduced to hand movement, eye feels hard, pupil might dilated, non-active, hazy cornea, ciliary congestion is there. So it is acute of angle causal glaucoma. And case 3, 25 years male, left eye pain, intolerance to light, redness and decreased vision, 2 to 5 days. And on examination, pupil irregular, small keratic precipitate in the anterior chamber, ciliary congestion, cells and flail in anterior chamber. This is anterior uveitis, sometimes called iritis or iridococcitis. Case scenario 4, 50 years male, bilateral redness, watery or salary discharge for 1 week, no problem with vision and no pain. What is this? Okay, it is viral conjunctivitis. Thanks for your hearing. Thank you very much.